All right, so let's start. Welcome, everybody. Today to our summer session for fetal cardiac MRI. And of course, it's our third webinar series, and I'm very happy to invite you for this session today. Again, a short information that this webinar will be recorded again, and then also be available online for you to watch it again. Some change to the other last webinars. I'm moderating together with my colleague Domenico Gulla today. He's our MRI application specialist at Northh Medical. Happy to be here with him. And of course, again, I would like to mention that it's our biggest aim to build a community, and I'm always repeating that. And we would like to offer a platform for networking and exchange. We have now about 90 or more than 90 SmartSync devices in the market. So we have many users right now that we want to connect and we want to exchange. That's why we are here today. And also, again, we would like everyone to participate. So please feel free to raise your finger. Please feel free to discuss, to ask questions. We are very happy to answer and help however we can. Today, we are talking about, or the title of the session today is Integrating Fetal Cardiac MRI into Clinical Routine. So we show you some insights from the field. And before we start with the session, or before I introduce our speakers today, I'd like to quickly have a short poll with you, because I think it's always very interesting to know with whom or who is in the community, and if we have beginners or if we have users, or if you are already well known in the area of fetal cardiac MRI. So you should now please take a look into the chat so you see the poll, and then please give an answer. And there you can already probably see the answers now. So there are about 42% that are already experienced with fetal CMR, and about 20% have just started. I wait a few more seconds. For those who just arrived, please take a look in the chat. There's a very quick poll for you that you can answer now. All right, and then I will directly move to a second question that I will be very interesting to know, and I will start it right now, which is whether you use fetal cardiac MRI as clinical service in your hospital. As this is our topic for today, it's very highly interesting to know who is already using fetal MRI or cardiac MRI as clinical service. Okay, and probably you already see the answer. There are about, most of you are not using fetal cardiac MRI as a clinical service, which is very interesting and good, because today we learn a lot about how to integrate it into clinical service. So that's great. So about 30% of people that are here are using it in clinical service, and the others not. Great. Okay, and then I'd like to quickly just mention that it's the goal, of course, from us, but I think also from the whole community, to establish in the long term fetal cardiac MRI as a clinical routine. And basically, we can distinguish into three main or basic areas, which is the first one, like steps of development. And the first one is the basic research and concept development. And the second area is the clinical use and research. And the third one, the last one, is the application in clinical standard. And actually, we wanted to include that in our last webinar session, but as it somehow didn't work out, I have included now this third poll question into our session today. Because I'd like to know from you where you see fetal cardiac MRI today as application. Do you see it in research? Do you see it in clinical use? Or do you see it in clinical standard? Okay. Most of you see it in clinical use and research. There are some that see it already in clinical standard. Okay. All right. Almost 80% see it in clinical use and research. Some 14% that see it in still basic research and concept development. And then there are about 9% who see it already in clinical standard. Thank you for this information. Yeah, and now I would like to show you how we believe actually exactly the same. So the first step, basic research and concept development, we believe is already concluded back in 2021. We believe that we are right now within the phase of clinical use and research. So what we do right now is to gain from day-to-day experiences for clinical use and its implications. And the future a little bit is to get really the implementation into clinical standard, and we see that it might be possible within the next 2 years. However, there are some limiting factors or challenges, and here this is a very short overview of a survey that we did last year with some of our users, and there are still limiting factors like referrals, personal, MR access, costs, of course, and image quality. And this is what we are focusing on also in the future. All right, with having said that, I'm very happy to welcome our experts today. It's Marjolein Piek from the Lund University, it's Tomas Woodgate from King's College London, and it's Domenico Gulla from Northh Medical. And I'd like to hand over now to Marjolein from Lund. And yeah, great to have you here, Marjolein.
Thank you, Heide.
You can share your screen.
Yeah.
Okay, that works. I can see your slide. Perfect.
Great. Good. So thank you, Heide. Happy to be here. Let us immediately start to say how the road is to fetal CMR in Sweden, because I think fetal screening is done differently in different countries. So in Sweden, we start with screening by midwife. We have ultrasounds at week 13 and week 20. And if there are any cardiac abnormalities detected, they will be referred to a diagnosis by a fetal cardiologist. If they then have suboptimal echo data, they can refer for fetal CMR in our hospital in Lund, Sweden, and we hope to get improved counseling from that. And then let's go over the timeline that we have. Well, we started actually back in 2012 with the first ideas. We received the first grant on a maternal heart, which then eventually led to actually fetal scanning. This was first initiated by Håkan Arheden, the professor of clinical physiology, Stefan Hansen, the head of obstetrics, and Anthony Aletros, an engineer from Greece. And then some years later, in 2015, we started actually doing fetal. Mike Seat and Chris McGowan visited us in Lund from Sick Kids Toronto. The first research scan was done, and at that time we didn't have the Doppler ultrasound, so we used metric optimized gating and self-gating for the cine images. And then in 2016, Eric Hedstrom, our pediatric radiologist, he visited Sick Kids Hospital to learn more after a year of experimenting in Lund. In 2017, Eric Hedstrom set up reimbursement in our hospital for fetal CMR specifically. We also had our first clinical referral. The Doppler ultrasound was introduced as a first. So we started using that, and then we started the feasibility study. In 2019, our PhD student Costas Harris developed a two-dimensional radial sequence with Doppler ultrasound gating, so we could actually have a cine in the fetal heart. Then in 2021, we published a clinical utility paper on fetal CMR. This was done by our PhD student Daniel Ruth. In 2022, he defended his PhD thesis on fetal CMR as a first in the world. And in 2023, I developed a three-dimensional cine sequence to capture the fetal heart in one go. We appointed technicians dedicated to fetal CMR. We actually had them choose themselves that they wanted to dedicate themselves to fetal CMR. So we have two very enthusiastic technicians now, Lotte and Johanna, and we scan about 30 clinical cases a year now. And then this year, in the beginning, we changed the MR scanner. We started on a very old model 1.5 Tesla Siemens, and now we have a modern version of that. And we also optimized our sequences to gain image quality. Just briefly, our clinical exam card when we scan fetal, we start by localizing the sequence to actually locate the fetus. Then we run a set of balanced SSFP fetal localizers, both for planning and diagnostic purposes. We've received this particular set of sequences from my seat in Toronto. And then to visualize the nutmeg lung pattern, we use Hayes sequences in the transversal and coronal plane, which is a black blot type of sequence. Then we acquire the balanced SSFP cine images in imaging plane desired for a diagnosis, which is always the transversal, but it could also be the fourth chamber or short axis, for example. Then we also measure flow in vessels needed for diagnosis, usually the main pulmonary artery and the umbilical vein. Then we have a three-dimensional vital volume, which is used to quantify the flow in milliliter per minute per kilo. This was developed by the Children's Hospital in Philadelphia, but we received it from Mike Seed as well. Then in case a Doppler ultrasound doesn't give us anything, which rarely happens, we have a 2D radial sequence. As you can see here in the cine image towards the right, which shows a transverse cine. And then we also have a T2-weighted single pass spin echo for slice to volume registration. And something else, fetal CMR can be used to visualize cardiac anatomy and cardiac function, but it can also be used to assess fetal cardiac physiology. And to perform reliable measurements, we choose to scan in the left lateral position, as in the supine position, the venous return may be blocked. And you can see that here in this figure. So in the figure here, you see the supine position, and the numbers 1 and 2 point to the aorta and the vena cava, and they are suppressed. When we then tilt the woman, as in image B towards the right, you can see that both vessels are no longer suppressed. And if the venous return is blocked, this impacts placental flow and circulation, which will affect perfusion and cardiac output. And then we also value maternal comfort, because a comfortable mother makes or breaks a scan. We work with an extra soft mattress, which was actually something that our dedicated technicians decided to buy from IKEA. So it's nothing fancy, but it makes it way more comfortable for the woman to lay on her left side. And then we pillow up. You can see the solid orange arrows. They point to a pillow under the head and a pillow between the knees. And in some cases, we also add an extra pillow in the back, which is indicated here by the dotted arrow, and it's not visible in this picture. And we think that both parents-to-be should feel comfortable with the MR scan, and that's why we also involve the spouse. For clinical referrals, we have 2 dedicated fetal cardiologists, Misha Bat and Katrien Frieke. They refer patients for CMR when they believe they will add clinical value in addition to their ultrasound exam. And they started doing this during their PhD studies. So this is an example case report from them, from Bat et al. In 2019. On the left here, you see ultrasound images from a 37-year-old healthy pregnant woman at second pregnancy. The echo showed a small left ventricle, unknown VSD, and a possible coarctation. The woman was referred to our hospital, and the fetal cardiologist performed an extra ultrasound week 36, and it was worse quality, so there was a referral to CMR. This was at 37 plus 4 weeks. And what we can see here, there was a small left ventricle, no VSD. So we can see a static image and a cine, but it did show arch hypoplasia as visible in the image towards the left and indicated by the arrow. Postnatal echo confirmed the CMR findings. And the cine image towards the right is a self-gated tiny angle eye grasp that was developed in-house. Clinical reporting. In the beginning, it was the fetal cardiologist with the pediatric radiologist together. It's to form a mutual language in reporting. Currently, it is the pediatric radiologist reporting. And reporting is also performed on extra cardiac findings, and that can be seen in the images towards the right. We can see changes in the vertebrae on the left and intestines on the right, and this raises suspicion of other malformations. And we will include this in the decision-making process. And sometimes the ultrasound exams may be included in reporting if needed for clarity. Clinical cases, we have approximately 30 cases a year. We get them from all over Sweden and even Iceland. Currently, we are the main center in Sweden, but in Gothenburg, they are starting up as well. As mentioned in the timeline, we did a utility study. It was conducted between 2017 and 2020, and we included 31 fetuses. They underwent CMR at a median gestational age of 36 weeks. And this is a flowchart of the included main groups. So in the top row, we see a suspected pathology, for example, aortic arch abnormality, which were the majority of cases. In the middle row, we show if it led to improved imaging. And in the bottom row, we can see if there were changes in the management or counseling. And just to clarify, here we see the numbers in which it made a difference. So in case of the aortic arch abnormality, it made a difference in 15 out of 20 for management or counseling. Overall, fetal CMR imaging has clinical utility, affecting patient management and or parental counseling in 84% of the cases. And more importantly, we had 25% direct impact on intervention. This is a case from the report from the study. On the left, we have fetal echo. It showed suspected aortic arch hypoplasia and irritation, as indicated by the arrows. However, fetal cardiovascular MR showed a normal size aortic arch, as indicated by the arrow, and no signs of coarctation. And this was confirmed postnatally with an echo. And we have a second case. We see an echo with a four-chamber image, and it shows an underdeveloped mitral valve annulus, as indicated by the pluses, and a non-apex forming left ventricle. However, they believe it was some image projection, and the woman was referred for CMR. On the CMR image, we show a normal size mitral valve annulus and an almost apex forming left ventricle with normal function. This was confirmed postpartum. A third case. Here on the left, we see a fetal echo with poor acoustic window. But on CMR, we could show there was a single ventricle with a large intra-atrial communication, as depicted by the asterisk, and there was no nutmeg pattern visible. A nutmeg pattern is indicative of pulmonary lymphangiectasia associated with poor postnatal outcome. And based on this, normal vaginal delivery was planned. And the last case I would like to share here is that fetal echo basically showed nothing because of an obese mother. Here in the top right image, we see normal sized ventricles and normal function. In the bottom left, we see the SVC, the aorta, and the IVC. And in the bottom right, we see a normal main pulmonary artery. But this information ruled out major congenital heart defects, and delivery was planned in hospital places to the parents. And postnatal echo confirmed these findings. So to conclude, there has been rapid development over a few years, including shown impact on clinical decision-making. Clinical examination by referral in several centers already. There's increase in wider availability in use of product sequences, as seen by rapidly increasing number of sites running fetal CMR. And for the future needs, background phase correction for blood flow in the fetus, likely, standardization of sequences, validated reproducible method, reference values throughout pregnancy, at least in the third trimester, and a consensus on reporting. Well, thank you for listening, and thanks to my colleagues in the cardiac MR group in Lund.
Thank you, Marjolein. So are there any questions from the audience? Thank you very much, Marjolein, for this very nice outlook. So it's crazy that you have also started very, very early, 2012. And we met 2 weeks ago during the AEPC in Hamburg. And you have been at our booth presentation, which was great. And Marjolein, you have shown us some images, and you have shown us that you have changed your scanner, and you have mentioned that before. Can Can you say anything about like image quality? How is it changing now with the new scanner? What other experience you are making? How many cases you have already scanned with the new scanner, and which scanner is it at all?
Yeah, maybe I should just share. I think I included that in my presentation. The slides you can
because I really like those images where you have compared
Yes.
the old images to the new ones. Yeah, feel free to share them.
Here they are playing. Can you see the
Yeah,
the slide? Great. Yeah, so on the two left images, they are on our newer scanner, and the two on the right are the older scanner. I think it's hard to draw conclusions from just these 4 cases. We haven't scanned that many cases on the new scanner, and I didn't see them all because I was on parental leave for most of the spring. But what we hope to realize with the newer scanner and with the optimization of the sequences is to just have a better contrast between the cardiac and the myocardium. I think that's what most people can see. And we hope to actually increase flip angles as well, which actually isn't showing here right now. We actually see the opposite, but that is our aim, to have higher flip angles in general.
That's interesting. I think my colleague Domenico is going to talk about that as well.
Yeah.
What do you have?
This is really interesting because how really this key parameter of the angle can change really exactly the border and then a contour of myocardial. So and then I will show also something about that. So really curious. Yeah.
One more question, Marjolein.
Yes.
One of our users, Marjolein, this is you, Malenka Bissell from Leeds. You probably all know her. I don't know if she's with us right now. However, I really found interesting during a last presentation from her during a teaching course in Warsaw, she has shown a spa approach, a wellness approach that she uses during the positioning of the women and how to introduce the woman into the whole application. And she was like mentioning that she has no fetal movement, almost no fetal movement at all. And that is very, very important, how to talk to the women and how to introduce them. And if also, like, I think she has the favorite color of the women, the light color and music and all these kind of things. And I really would like to highlight that also for the rest of the community, that this is very, very important to really decrease the fetal movement during the scan, that you have a comfortable mom. So yeah, probably you can, you agree with that, right, Marjolein?
Yeah, I definitely do. I'm happy to learn from Malenka next week at the workshop.
Oh yeah, right. Yeah. Do you have any other tip regarding that, or?
Well, what we see, and I think that's in general, that the longer the woman lays in the scanner, the more fetal motion there will be. It is inherent to being pregnant. Once you start laying down and resting, the baby starts to move. But also, the scanner is like a stressful environment, usually for the mom, especially when they are clinical. So I think the sequences that you think are most important for diagnosing, they should be run first.
Yeah, all right. Thank you, Marjolein. And whenever you have more questions, also from the community, don't hesitate, just post them in the chat, also later. All right. With that, we would like to hand over to Tomas Woodgate from King's College London. Thomas, I'm very happy to have you here today. And also King's College London has already implemented fetal cardiac MRI into their clinical service. So yeah, we will learn now a second approach, how London is doing that. Thank you, Thomas.
Okay, thank you. And thanks for the great talk, Marjolein. So my name is Tom Woodgate. I'm a clinical research fellow and PhD student at King's College London, and I'm going to talk about our own experience with fetal cardiac MRI. So I'm going to outline our clinical service, go through our own patient pathway, which is fairly similar, talk about some of the referral patterns we have and some of the challenges we face. So just to recap, so just King's College London is the university that we work at, which is in partnership with the Guy's and St Thomas's NHS Foundation Trust. Our clinical pathway, so I've taken this picture from this nice review paper by Desmond et al. In 2023, and it shows more or less a kind of similar thing to what was displayed before, where patients will at some point make their way to fetal cardiology, be that on the basis of an abnormality being detected on screening or risk factors. And in certain cases, fetal cardiac MRI will be requested. I would say a slight difference to this is I'd say it's very rare that we have cases where there's a particularly unclear prenatal diagnosis. And in our own practice, it's more that they're selected cases where additional imaging from fetal cardiac MRI may be valuable. And we'll talk about what those ones are. So we're kind of very embedded with our fetal cardiology service, where and our and all our referrals will come from fetal cardiology. We scan patients between 30 and 32 weeks usually, sometimes a bit earlier or later. And we scan on a 1.5 Tesla scanner, for the most part, there's a Siemens solar scanner. All of our patients receive cardiac, brain and body imaging and reports. So we, as cardiologists, we do the cardiac reporting, and we have special fetal radiologists who do the brain and body reporting within our own service. The fetal cardiologist will feed back the results of the report findings to the patients, and will often have a later ultrasound scan after the report is back. And in some cases, fetal cardiac MRI data may be presented at case conferences or other meetings relevant to patient care. We scan about 4 patients a week, or we have 4 slots. We try to limit our scans to about 1 hour in duration, but our slots are quite a bit longer than that to mean that we don't have to rush too much. So the slots are about 2 hours long, which gives us enough time to make sure we can kind of get the patients on the scanner and comfortable, site the Doppler device, and yeah, really sort of have a bit of time to allow the patient to have a break if necessary, and just deal with any sort of time delays that happen in clinical practice. We, contrary to the previous group, we tend to scan our patients in the supine position actually, and similarly our scans are free breathing. We have a once weekly clinical reporting meeting, and we aim to turn around all of our clinical reports within 2 weeks. Usually it doesn't take the whole 2 weeks, and if it's a particularly urgent case, we can turn it around within 24 hours. For our reports, we would always include several things. So we often include vascular measurements if relevant to the diagnosis we're looking at, and also flow data. And main thing for us, I'd say, is lots of images. These can be really helpful to just provide visualization of what we've seen during our scan. This next thing is sort of why we referred patients, and this is something we think about a lot, is which are the best patients where fetal cardiac MRI can add value to. And in our own practice, it really falls into 3 main groups. So we have cases for risk stratification, vascular visualization, and intracardiac visualization. A big group that we see are cases of suspected coarctation of the aorta, and our goal there is to try and quantify the risk of this patient needing an early neonatal intervention. There's other cases, like we said before, looking at pulmonary lymphangiectasia in cases of HLHS or TAPVD, and some other sort of more niche indications where risk stratification may be helpful. A lot of our referrals relate to vascular visualization, so that's either of the aortic arch or ductal arch or unusual ductal anatomy, or looking at the venous anatomy, so cases of anomalous pulmonary veins or abnormalities of the systemic veins. We can show these really nicely in 3-dimensional space. We also have some referrals which are more primarily for intracardiac visualization. So this would be cases where there's complex intracardiac morphology. So looking at things like the ventricular arterial relationships in cases of double outlet right ventricle, or cases where there's abnormal ventricular relationships. So things like supero-infero arrangement of the ventricles. It can be really nice to look at where those fit in the fetal thorax on 3-dimensional imaging. We also see some cases for tissue characterization of cardiac masses, and in some of those, additional brain imaging can be really helpful. So for instance, if you had a case with a rhabdomyoma, are there any brain findings consistent with a diagnosis of tuberous sclerosis in that patient? That could be a valuable additional benefit to the MR. Another category that kind of covers a lot of the above are the laterality disturbances. I think they're a really nice use case of fetal imaging. So we can get really nice vascular imaging and also an assessment of, pretty much all of the organ systems in their body which may be affected by these types of conditions. But the sort of point here is that it's a really heterogeneous group of indications and cases that we see, and it's not limited to this. We're really open to discuss any possible cases with our fetal cardiology team about if they've got any queries about a case where they're, wondering whether we may be able to add anything with an MRI. Thought I should also talk about the challenges we face or limitations. Here's some limitations which were, many of these were actually very nicely covered by Milenka's talk at the previous webinar. So these are all things that make it more likely that you're going to have poor data quality. So these are things like patient discomfort. We try to limit that as best we have. We have very, experienced radiographers who are very good at getting the patients comfortable and trying to support them throughout the scans. But yeah, for some patients, they may struggle with remaining still during the scan, and sometimes the fetus, even though we do some motion correction, sometimes fetuses can be particularly active. That's not super common that happens, but from time to time we've got a fetus that just doesn't really stop moving throughout the scan, and that can be a challenge. Other things like polyhydramnios, elevated BMI, or twin pregnancies, sometimes you can have issues with poor signal in these cases. But I'd say it's really important to try and screen for some of these things at the time of referral. There are also some things that are related to risk of patient safety during the scan. So as we scan supine, so sometimes patients can develop hypotension. That's relatively uncommon, and if it does happen, we would just move them to the left lateral position, but it's certainly a consideration. So we do put monitoring equipment on during our scans. And another thing, because we're monitoring them for hypotension, we do sometimes come across patients who have poorly controlled hypertension. And as you probably know, poorly controlled hypertension can be problematic in pregnancy or can be associated with neurological events. So we've got quite a strict departmental protocol for handling cases where uncontrolled hypertension has been detected, and that will mostly involve not scanning them and until their hypertension has been controlled. Some limitations which are more related to our imaging. So with the venous anatomy, I think even though we can often pick up PAPVD, it can be quite tricky in some cases. So if you've got PAPVD of like the left upper pulmonary vein to the innominate vein, that can be very nicely shown. But if you've got the right upper vein to the SVC, that can be tricky if it's low down. It can look essentially normal, or you can overcall it because there's lots of structures on your black blood imaging behind the atrial mass. So you'll have pulmonary arteries and their branches, systemic veins and their branches, and airway branches, which can all be easily mistaken for veins on your black blood imaging. So yeah, a bit of caution about the PAPVD of the upper veins. And another thing, this was also shown in the last webinar, that was a case of TAPVD to the coronary sinus. We've had one case where it was, they came to us with a known diagnosis of this, very clearly defined on the fetal echo imaging, but even though we knew it was there, it was very difficult to say with confidence that we could see it based on our own imaging. So I would, echo the caution about this type of condition. Arterial anatomy. So sometimes small AP collaterals can be beyond the imaging resolution that we have. So we've had some cases where they've been noted postnatally, but we're not able to see them on the prenatal imaging. Then with respect to the intracardiac visualization, some of the limitations, I think ventricular septal defects are really challenging sometimes. So if they're small or in the perimembranous region, they can be a little bit tricky to assess. And kind of on the contrary, we can sometimes visualize defects that or things that look like a defect that are artifactual. So sometimes in the apical region, you can have signal changes that may look like a defect, but haven't been shown on the echo either pre or postnatally. And then just a word on our tissue characterization for the masses. Sometimes this can be quite limited, or our assessment of this can be quite limited, but can still be valuable. Here's our scan overview, which I won't spend too much time on, but we cover similar sorts of things to before. So an image of the whole uterus, which we use to get to segment the fetus and estimate the fetal weight. We do a similar thing. We spend quite a lot of time on our black blood data, so and we have dedicated body and brain imaging of this, and these are all reconstructed. We have an optional break in our protocol between the first section, which is kind of static imaging, and the second section where we do our dynamic imaging. So this is, we use about 20 minutes of cine and flow data. Does depend a bit on what the referral indication is as to how exactly we protocol the scan, but this is an overall kind of idea that we do. Also, let's talk about some sort of tips from using things like the SmartSync in clinical practice. A main thing I would say is definitely you want to try and sight the band before getting the patient on. Sometimes we forget to do this, and it's just much slicker if you've got the band there before the patient's on the table, so you don't have to sort of feed it underneath them or something. When to apply it, I think this depends on your protocol. So we find that if we position this at the start of the scan, it definitely saves you some time. So then you're not having to take the patient out, take the coils off, and sight the device, put the coils back on and push them back in. So we try to put this on at the beginning because it saves time, but if we're struggling to find the best location, we will not spend too much time and we'll put it on later. So if you position it later, the advantage is that you can then use the imaging data to sort of really help you position it optimally. Here's like a horrible diagram, but kind of illustrates what I find quite helpful. So again, we're scanning supine, and I find that often these are good positions to sort of start with when you're thinking of where to place the Doppler. So just at the level of the umbilicus, or just below it. And this is because the fetus is often going to be in this type of position. So if they're cephalic, at least at this gestation, their heart is often around the level of the umbilicus. They'll either be in like this type of position or the mirror image of that. So those are my sort of go-to starting positions when sighting it. Obviously, the fetus can be in any position, but it's a good place to start. And if left lateral, we don't have so much experience with that. So often I'd rely a bit more on the imaging data to support where to put it. Now, just some cases to cover sort of what we're looking at. So this is a kind of common type of case we might see. So a case of suspected coarctation of the aorta. So here you can see on the Doppler ultrasound gated cine imaging, we've got this ventricular disproportion as you see before. So small left ventricle, big right ventricle. And on our black blood imaging, you can see there's also well shown as the disproportion at the arterial level. So we've got a much bigger arterial duct than our aortic arch in these transverse planes. We can then navigate through these DSVR reconstructions and get sagittal planes, which we're very confident are true sagittal cuts. So here's a nice ductal cut. So main pulmonary artery, arterial duct continuing to the descending aorta. So showing the ductal arch, and a similar thing for the aortic arch. So here you can see the ascending aorta, and in this case it continues, and you can see it is narrow, but it has this nice confluent contour, and continues on with the descending aorta back here. We can see that in 3D again, and this is the type of anatomy where you have, or the type of morphology of the arch where you definitely have this arterial disproportion, but you're not seeing significant displacement of this aortic isthmus. It still looks, you've got this nice contour between it and the descending aorta. We use the process that's outlined in this paper from Circulation to take anatomical measurements of this type of data, combine that with some phase contrast flow data, and come up with a quantitative risk of coarctation of the aorta. So in this particular case, even though you've got quite significant asymmetry, we were able to produce a percentage risk score of coarctation of less than 10% in this case. We then feed that type of data back to the referring cardiologist, and it's sort of up to them how to assimilate that with the rest of the data they've got from their imaging, and decide on whether this is a patient that they'd be happy to deliver locally, for instance. Are we doing okay for time, Heidi? I have just one.
Yeah, you should. We have a few questions, so we need some time for discussion. So you can come to the end shortly.
Okay. I have just a quick one of just another use case is the vascular visualization. So a type of case we might also look at is these right arch variants. So in both cases here, you can see you've got a right arch and a left arterial duct. In the case on the left, this, and you can see how on both of them, you've got a vessel here with the asterisks, and in your transverse planes on echo, these can look quite similar in a plane. But on the left, you can see that this is a left arch, making this a double arch. And on the right, it's a brachiocephalic artery, making this a right arch with mirror image branching. These can be very nicely demonstrated in three-dimensional space, where you can, again, appreciate that there's no continuity between your brachiocephalic artery and the descending aorta. And this is a useful case because we see these postnatally, they may look very similar. So this is an example of a fetus who had a double aortic arch. And postnatally, what's happened is they've underwent atresia of this distal portion of the left arch, and they've ended up with an arch that looks on this postnatal CT scan very similar, if not indistinguishable, from a right arch with mirror image branching. So there's a sort of unique diagnostic window or opportunity to get the diagnosis right in fetal life for these cases. So we sometimes see image cases where there's a suspected double arch. Yeah, so those are some examples. But I'll leave it there. Thank you.
Oh, thank you, Thomas.
Thank you.
Thank you very much. Yeah, this is, I think that was very clear, the implementation, and I think it's enormous that you have 4 scans per week. Since how long do you have 4 scans per week? Like, did it just increase by time, or was it like on a certain time point you got like the referrals?
I have to say, it's been that way since I've been here, which has been the last 2 years. So I'm not sure for how long it's been going back
Okay.
at that length before.
Quite high number. Good. All right. There's a question from Ramdani. Is there any dedicated advanced coil which aims to enhance the signal to noise ratio and dedicated for fetal CMR?
I believe that there isn't. In our own experience, we use a combination of a body coil and I think a spine coil for ours. And I think different centers have come up with different different coil setups that we've seen. I'm not sure of a dedicated one for fetal imaging. I don't know if you have an idea. Anyone else?
Yeah, or anyone else as well, right? Yeah.
Maybe it's like,
yeah,
I think also there is like some third company that provide coil just adapted for fetal and adult pediatric patient. I think it's Ink Space, and we met also during the conference in Miami during the pediatric radiologists conference. And honestly, I don't know the results, but I think it's also they are working on that.
Might be the future.
Might be the future. So something that can improve the SNR.
Yeah, Kieran.
Yeah, only to say with coils, I think that you can get bespoke coils, but most people share the scanner with radiology, and these coils are really expensive. So the practical solution is to use existing coil combinations for your images. And it also depends on whether you put them supine or left lateral, because the coil configuration in a supine position can be quite challenging.
Right. Thank you for your comment. Then do you want to answer to the question about deep learning techniques? So is there any knowledge about deep learning techniques from you, Thomas or Marjolein?
I can't see the specific question, I'm afraid. Is there?
It's in the Q&A. It's just like the question was, what about deep learning techniques? So if there is any knowledge also in the whole community, but we can maybe, if there's someone wants to comment, you can also comment in the Q&A. And I will just then jump to the next one from Michelle Udine from Washington. What is your process of communicating the results of fetal cardiologist patients and the limitations of fetal CMR? I think this is a very important question that I'm happy to hear the answer.
Yeah, well, from as in about the limitations of of the scans. So we work very closely with our fetal cardiologists, and if there's doubt about the particular data quality in a scan, or if it's an unusual case, we'll often go and sit with them and go through the data together. I think that can be quite helpful to so that they can sort of know what our own thought process was with the imaging. Yeah.
Mm-hmm. Mm-hmm. Yeah, Marjolein.
Yeah, I agree with
You wanna
Thomas
add?
here. I think our sequence development is really closely together with the pediatric radiologist who is reporting on the cases. So they are aware of the limitations of the sequences and what they should be paying specific attention to. I think this communication is very important between engineers and clinicians.
Mm-hmm. Yeah, probably the best approach, right? Okay, due to time, we will now directly hand over to Domenico, because maybe some of you know him already or met him during remote sessions or on-site sessions. Yeah, as of course, image quality is the most important thing when we talk about clinical implementation. Domenico wants to show you some tips and tricks, technical, helpful information. Oh,
Sorry.
About how to best implement fetal cardiac MRI.
Okay. Hi, everyone. I think it's the same program.
Right.
Okay. I can just close mine.
Yeah, close yours. So you have this one.
Okay, mine is closed. Okay. Okay. Hi, everyone. I'm Domenico, and I'm the clinical application specialist at Northh. Today we're talking about like clinical implementation, AI image quality. Sorry. Okay. So I want to give an overview. So a presentation overview, and this session is dedicated to explore CNS sequences as key component of hybrid imaging methodology, with a special focus on optimizing technical parameters that truly make differences, such as flip angle, spatial, and temporal resolution. We will also highlight how close collaboration with the customer, both remotely and on-site, translates into a really tangible improvements in protocol performance. And this presentation reflects the value of a focus and approach to protocol improvement and the clinical impact of the continuous support. So over the past 2 years of on-site, remote, and live demo support, one message is that I always try to share to both technologists and clinicians is this, that fetal cardiac MRI is a hybrid method, a dynamic fusion of fetal MRI and cardiac MRI knowledge, requiring both technical precision and clinical intuition. It's not just about running a protocol, it's about being smart, fast, and focused, adapting to the needs of the fetus, to the mother, and the clinical question. So that's why fetal cardiac MRI, it's unique. So, and the core of the principle of fetal cardiac MRI, so for my opinion, for my experience, in this case, during the session, so what is really important, starting from the beginning, it's like, don't waste time finding the fetal heartbeat. Start with the fast localization of images, axial and sagittal, and use anatomical landmark like the umbilical, placenta, iliac crest, lumbar spine, and fetal side. You can also measure in centimeter on the images directly on the MRI console to guide precise device placement. This helps also technologists become more familiar with the fetal and fetal cardiac anatomy. So second step, it's have a clear plan, because know what anatomy must be visualized based on the clinical question and which sequences you need. then think more anatomically and not standard. So tailor each cardiac set to show the specific structure needed rather than following a rigid cardiac MRI protocols. Because of course we are using cardiac MRI sequences, but we are talking about fetal cardiac MRI. And speed is essential because fetal movement demands short, robust sequences, minimize the scanning delay. Once the fetal heart is identified, begin seeing it as soon as possible to avoid position change. And then decide the protocols to minimize maternal fatigue and effort. So alternate sequences, also free breathing and breath hold sequences. Keep breath hold short as much as possible, and monitor fetal motion through the waveform. So, and the breath hold based scene are the gold standard for morphology and function and must be acquired in a really short time, so 4 or 6 seconds per slice, to avoid missing cardiac trigger or losing the window due to the fetal movement. And the last really important things, it's the maternal instruction that are vital, because before the session, it's really important to instruct the mother to hold her breath during the sequences of breath holding. And also it's really important to communicate continuously during the acquisition to the mother, to understand also if in that moment the baby is moving, because sometimes we figure out that the sequences are really full of artifact. So here, we were talking about Cine, and the Cine sequences, and as I say, the gold standard is Cine breath hold. This is a bit like what I suggest to the customer during my support that is on site or remotely. And this is all the parameter that, of course, we suggest, and to get a really nice image quality for 3T and 1.5 Tesla. Of course, everything is relative. We have a gold standard, we have parameter that we suggest, but of course, everything goes through also the request of the clinician, because sometimes I got requests because someone wants specific field of view and someone wants to improve more the spatial resolution. And of course, we have a standard protocols, but everything is always in continuous improvement. So, and here I'm really happy, and I would love to share the exam card and to support if someone needed, of course. And here it's an example. It's just on the left side, it's just a sinus sequences.
Yeah, now we see.
Okay, now you can see. Okay, perfect. It was a bit slowly. And on the left side, you can see they are the same patient, the same sequences, and they are just 3 different sequences. And the first one is just with the normal field of view that we are used to scan, so like 300, or between 250 and 300. So in this context, the clinician asked me also specifically just to see the heart bigger, and then to have just a focus on the heart and not to see also the other part of the anatomy. So, and this is also something that is possible. So, and it means that we can also change the field of view, reduce the field of view, and then improve also the spatial resolution in base also that.
We cannot see the
moving.
movie.
It's a bit slowly.
It's static here with us, but
okay, sorry for
should
that.
move actually.
Should move.
On your it looks better.
Okay. And okay, now we just jump on the key technical parameter that matter. So flip angle. Flip angle also, Marjolein was talking about that. And flip angle is made larger to accentuate T2 and T1 contrast and produce bright blood images. In Cine sequences, higher flip angle improve contrast between the myocardium and the blood, and making it easier to see the heart wall clearly. And here I'm just a bit moving on what is like more the Cine sequences and what is the optimal flip angle in cardiac adult acquisition. And here I found this article that I back in Guyana, in this case, shared with me these 2 slices, and this is an article of Zrin Bassan. And in this case, we can just look at the conclusion and so, and then for very high blow myocardial CNR can be obtained with a flip angle of 105 in the short axis plane and 75 in the 3-chamber and 4-chamber images plane. So that doesn't mean that for fetal cardiac MRI, everything needs to be adapted like the adult. For fetal cardiac MRI, of course, it's a bit challenges due to the SAR. And in this case, I want to show you also, like here, there are like some cardiac adult MRI images seen in short axis, but it's just to show you how it's really changing this parameter, the flip angle. You can notice is how change exactly also the differences between blood and myocardium. And I hope now that you can see also the movement. And maybe it's a bit slightly, but this is also what happened. So in fetal cardiac MRI, we can also do that, but with a slightly difference in acquisition. And here, for example, it's cases of 1.5 Tesla. It's a cases of gestational week of 27. And in this case, I was really lucky because there was not so liquid. The baby was.
See that, Domenico? Just as information, it will probably come up quickly. Yeah. Now.
Okay, now we can see. So now we are gonna talking about fetal cardiac MRI, no, and how is the flip angle in this case. And here it's cases of gestational week of 27 or 1.5 Tesla. And I was lucky because there was not so liquid and movement of the fetus. And I got these images and I tried also 2 different flip angle. And you can see how the images change, also changing this specific parameter. And here on the right, you can see this multicenter study published that also during the study they used a different range of flip angle between 44 and 75. That basically what we suggest for 3 Tesla and 1.5 Tesla. And the only thing that needs to be considered that the flip angle affect, of course, the image contrast, but also increase the acquisition time, and we have limit with for the specific absorption rate. Here it's another cases, for example, and it's always a 1.5 Tesla, and we have a cases of on the upper part flip angle of 55, flip angle of 65, and on the left static images, and here the video that I hope you can also see a bit, and you can see how the images can also change in this case, and also it's more uniform. Also the entire image is also around the body of the baby. So now we go on the other key parameters, that it's the spatial resolution. And here in this case, it's really important because in MRI, everything is connected. All the parameters are connected, and every change, and if you want to change the field of view, you need to change also spatial resolution and different parameter. So in this case, from the left to the right, we can see resolution images, and on the right side, low resolution images. And in this case, a 3T scanner with a flip angle of 65, and you can see also in the note, which is the resolution. I will just run the video, and let's wait a bit that everyone can see also that. And you can see also the differences in the resolution. It's the same cases. And of course, why do that? Because on the right side, the sequences, it's faster, it's shorter than 1 minute, and then it's 2 slides per breath-hold. So you can expect to have also like some blur rates or some ghosting images, but of course the resolution is completely different. So, okay. Now it's another key parameter. It's the temporal resolution. What is the temporal resolution? It's define how many time points frame we captured in one heartbeat. Higher temporal resolution is smoother, more accurate motion imaging. Why it's important? Because it's essential for visualize valve motion, myocardial contraction, and the end systolic phase, and affect images sharpness, ejection fraction calculation, and post-processing reliability. So, and here also an example how so it's possible to calculate the temporal resolution. Of course, the temporal resolution in the fetus, we are talking about heartbeat that it's the range is between every time 110 and 170 heartbeat per second. And of course, we suggest also temporal resolution. I'm really happy to support the customer if they need to improve that. So here now I want just in my last part of my presentation, just how we improved also the protocols. And here are some images of Michel Udine from Children's National Hospital of Washington. And we work very close and support remotely Michel. And in this case, it's how on the upper part, how looks like the protocols and the images before, and of course are nice images, but that every time something can be improved. And of course, we tried to reduce all the noise in the images, increasing the flip angle, and also trying to change the spatial resolution in this case. And in the last images is the...
Can you move the, can you get the video
move again?
playing?
Okay.
We didn't see it.
It's not going.
Maybe it's difficult.
It's a bit challenges that.
Doesn't matter.
Okay. So, and in the last images, in the last slides, I want just to show this is during an outside support in 2 different sessions and 2 different times. And in this case was in Marseille, in the clinic Bouchard with the Guillaume Coricor. And we did the first examination of fetal cardiac MRI. And of course, the first time it's difficult to get really nice image quality, because it's not so easy. It depends the patient, depends everything. And then the second time we tried to improve it, and then we got, in the lower part you can see the 3 images. We got really nice image quality, and this is gestational week above 30, and then on 1.5 Tesla. And we have the images from the left of the arch, of the 4-chamber view, and then the short axis view. Thanks to everyone.
Can you switch off your microphone again? All right, Domenico. Okay. Was there a question? Yes, I think there is a question. I just go to the chat. How much is the body weight you use for fetal CMR? No.
What?
How much is BW you use for fetal CMR?
I guess it's bandwidth.
Bandwidth, right.
Yeah.
Thank you.
I need to check it, honestly.
You need to check?
Yeah.
Okay.
But
we can
really happy to...
We can get back to you, Sadek. And Domenico will answer you this question later. Bandwidth, yes. Thank you very much. Okay, we are over the time. Sorry for that. Usually we try to make it. When you have more questions for Domenico or also for the other speakers, you can still contact us afterwards, and we can forward questions or also help you to find the right connections here in the community. There was a question actually via email before from Aarhus by Anna Mogelhoy. Anna, If you want to ask your question, or maybe it has already been solved during the presentations, otherwise get back to us and we will talk about it later. It was regarding a suitable software program for volumetric analysis, but maybe we could also solve it with our internal post-processing software that we use from King's College London. All right, and now Marjolein was also answering to the question and also some other answers. Thanks for that. Okay, I just quickly want to, I think we need to share it again. Yeah. Want to finish here, and I don't want to miss to mentioning that we will be at the Fetal Medicine Foundation next week in Prague, Northh Medical. Two of our colleagues, Sarah and Lea, will be there during all the days. So if you are there and if you are interested in chatting, talking, exchanging about fetal cardiac MRI or about the post-processing software, we are there and are very, very happy to meet you. And we'll also be in Hazelwood Castle next week. So there's a second fetal cardiac MRI workshop on Monday and on Tuesday next week. And also there we are very happy to get an exchange with you and to move the whole community and the whole society forward. Having said that, I'd like again to thank the Fetal Heart Society for all their support, as well as the Society for Cardiovascular and Magnetic Resonance, the SCMR. It's amazing to cooperate with you, with all of you. It's lots of fun, and we are very much looking forward to continue this journey of fetal cardiac MRI. And having said that, we are happy to see you in autumn, or for the autumn session. This will be in September 24th. Yeah, make sure you register and be part of it. And if you want to actively participate, please just send me a short email and let me know, and then we can think about possible participation. Would be very happy to invite you all again. Thank you for your time. Thank you for your input. Thanks to the speakers. High interest, very interested. Very interesting. Have a good afternoon, day, whatever. Bye-bye.
Bye.
Bye-bye. Wow, so many.
Bye.